So thank you very much, everyone who's here and who's joined us. There might be more people just sort of coming in a couple of minutes late, so you should still be in time for speakers. For those of you who don't already know me, I am Ali Errington-Orr, and I'm the Director of Marketing Communications here at PRSB. Recently, we've been running these thought leadership events, trying to think up relevant and interesting topics for the health and care sector. And to be honest, I've been trying to pull together an AI one for quite a long time, and this one's worked out really nicely with the experts we have ready to speak. AI is such a broad topic, and it's everywhere. Not new, but absolutely everywhere. And I imagine everybody like me is seeing it specifically related to health and care at the minute. We decided this time for this event to focus on ambient AI because I feel like it's becoming even more of a hot topic with people actually using ambient AI tools now. So what we've done is pull together a whole number of expert speakers to talk about the advantages, disadvantages, challenges that can be found with using ambient AI in healthcare. With the sort of release of the NHS 10-year plan, obviously heavily featuring the move from analog to digital, so tech is included in there. This topic is probably more relevant than ever. I noticed as well an NHS Confederation report about AI specifically for communications for the NHS was released a couple of weeks ago now as well. So hearing more and more across the sector. What I hope to do with this event though is if we manage to pull out some key themes, we'll try and host some other events, and we're always happy to hear other people's thoughts about topics that would be interesting. So following this event, if you do want to get in touch and suggest any additional topics, by all means do that, or volunteer for speaking. And so today I've got 4 expert speakers lined up to talk to you about ambient AI in healthcare. The format of the event will be is fairly informal, and we want to get as much from our speakers as possible. So my suggestion would be let our speakers chat. We've got a couple of panel questions arranged at the end, and then I'll open it up to the audience. And you can feel free to stick up your hand at the end or pop a question in the chat as well. If you don't mind staying on mute other than when you're asking a question, that just means our speakers aren't disturbed and we can sort of hear the things that they have to say. So our speakers that we have to chat to you are, we've got up first Professor Wahbi El-Bouri, who's a senior lecturer in health digital twins from the University of Liverpool. And then we'll be moving on to Dr. Nilesh Bharakhada, who's the clinical director here at PRSB. Dr. Ross Coomber, who's a consultant orthopaedic surgeon at St George in London. Hopefully I got that right there, Ross. And then finally, we've got Michael Almeida, who's the director for healthcare at Capgemini. So a really interesting lineup with a diversity of expertise. And I will be quiet now and let you hear from Wahbi. Thank you very much.
Fantastic. Thank you very much. And good afternoon, everyone. So thanks for the invitation, Ali. It's great to be able to talk to you. As Ali said, I'm an associate professor in health digital twins at the University of Liverpool, where what we're trying to do is develop technology to personalize medical intervention by having some online continuously updating twin. But I'll go into that a bit later. I think here, as kind of the researcher, the university researcher, I think what I'll be talking about is a bit more kind of blue sky research, and the others will give you, I guess, much more kind of practical kind of insight. I think what I'd like to talk about sort of in themes really is about ambient AI initially, how that relates to kind of what I call health and well-being, a bit about digital health twins and what I mean by that in research, and ultimately data. So the data that comes from all of this and that's required to run it. So I'm not going to assume everyone knows what ambient AI on the call, what ambient AI is on the call. So for those of you who don't know, think of it as some AI that exists in the background. So really, you don't necessarily interact with it. So a good example of this is clinical note taking in a clinic, where a microphone will pick up what the clinician is saying, and an AI tool will kind of gather the information that's required to build a report, and then it kind of reduces the workload at the end in terms of writing reports. So it's something that's going on in the background. Now there's some other use cases of ambient AI, some of which is being developed in Liverpool, where you can use, for example, cameras, thermal imaging, as well as microphones. If you imagine you've set up some sort of care home or something, and these cameras, the thermal imaging sensing can detect when things are going wrong. So it can assess changes in gait, changes in noises that may be occurring. And so when things are going wrong, can set up an early warning system. Right, so the ambient AI can also work in this sense where you're developing early warning systems for things that are going wrong for individuals in care homes or in assisted living. So the more data that we can collect on individuals, this allows you to collect data on individuals in a continuous or semi-continuous fashion, the more you can personalize these models for a specific individual. Which brings me to this idea of health and well-being. So, you've already mentioned the NHS 10-year plan, and they've recently released the life sciences plan as well. And there's a huge focus in there on pivoting from treatment to prevention. So there's a really, really big focus on preventing illness. And I think it's much needed, long overdue. I think the only way we reduce the burden in the long run on the NHS is through prevention. And when discussing prevention, there are two types of prevention I want to kind of think about, which the first being preventing sick people from getting sicker. So preventing recurrence of stroke, or if a stroke patient developing dementia or something along those lines. The second, however, I think is more crucial, is trying to keep people healthy, so stop them from getting sick in the first place. Now, if we want to build models that help us there, we require data, and NHS data intrinsically is the wrong type of data for that, because it's data of sick individuals. The more contact you have with the NHS, the more data there is on you. And so if you're building these AI models using that type of data, it's just not going to work so well at keeping healthy people healthy. So we need data on these healthy individuals. And that's where kind of these wearables and ambient sensing systems come in, which will allow us to collect this data, help us understand when an individual is deteriorating, or what sort of patterns keep individuals healthy. And so you're moving from kind of a snapshot type data, which you collect every time you visit a GP or an NHS service, to a continuous or semi-continuous data that's collected on individuals, either through ambient sensing or through kind of wearables. And this allows us to move to kind of this framework is what we're trying to build here in Liverpool, of these what we call digital health twins. Now, see if I can just share this one slide, and hopefully, okay, that did not work. Apologies. Let's see if I can find it. There we go. So hopefully you can see that slide. This is the framework we're talking about when we're talking about digital health twins, which is your patient health record along with this monitoring data, these wearables, this ambient data, which is held in some sort of storage system, which we do need to think about, that allows us to update models. And these models include both AI models that allow us to make predictions, as well as any mechanistic models we can discern, right? So we don't throw away the biology and the physics. If we have an understanding, we can develop these mechanistic models as well. And this kind of continuously updates, right? As more data comes in, you're continually updating this twin or avatar of an individual. So data storage will become a big issue. And here I've kind of given an idea of a data storage where we use some sort of blockchain technology in which we can store safely or something along those lines. But if we're continuously collecting data, and it's going to the cloud, how do you store this data safely? We're having a lot more data being collected. Where does it go? How safe is it? These are sorts of things we need to think about. And the reason I say that is because the success of these large language models like ChatGPT primarily comes from the fact that they had really, really good data. So they spent a very long time cleaning and tidying data. And as you know, health record data is never clean, it's never tidy, there's always stuff missing in it. So wearables, ambient sensing may be able to play a part in this, in kind of allowing us to collect semi-continuous sort of good physiological monitoring data, but it's not going to solve the problem of, for example, poor imaging quality or just kind of data missing from NHS records. So to summarize, I would probably say there's a real opportunity with ambient sensing and AI, particularly for prevention. I think that's where the real key is going to be. It's sort of long-term future. And hopefully we can see it used increasingly with these sort of frameworks we're developing in terms of health digital twins and digital avatars. And that's, I think, enough for me to talk about right now. And I'm sure later on we will have a discussion.
Thank you so much. That was really interesting. I've already got some questions, but I'm going to keep them till the end and just see what everyone else covers as well. Thank you. I'm going to hand over to our very own Nilesh, who's going to be our next speaker. Thanks, Nilesh.
Thanks very much, Ali. Hi, everyone. I'm Nilesh Bharakhada. I'm a GP based in Uxbridge. I'm also PCN clinical director. Have a strong strong interest in digital health, and I'm also exec clinical director at PRSB. I think in terms of sort of my talk, I think I've got about 5 minutes or so. I'm going to focus mainly on AVT or ambient voice technologies, simply because that's in my sort of sphere of direct experience. And I think what I want to do is just probably spend 5 minutes, firstly, sort of talking about what we mean by ambient voice tech, how it works in practice. Secondly, why it matters and why it matters now specifically, as opposed to, even as close to 6 months or 12 months ago. And also thirdly, how we can really make sure that we safely adopt this in practice. So I think if we start with I suppose the basics. Ambient scribes essentially ambient voice technology is essentially AI-driven tools that listen in on clinical conversations. Usually these conversations in general practice certainly are between patients, the clinician, carers, next of kin, other members of the family that may actually attend as well. So actually you have an advantage here immediately, whereby you're able to record notes from a series of people within the room. What it then does, it automatically generates a consultation summary. And the way they work essentially is they use a mixture of speech recognition, natural language processing, and now generative AI. We've obviously had speech recognition in the NHS for decades. I've sort of used this in the past as well. And the early version simply transcribed the consultation and left you to do all of the editing. However, with the addition of generative AI, large language models, the capability of the ambient voice tech has obviously exponentially increased. And they now do things like summarizing key points as opposed to just transcribing, which is what we were used to. What they can do is summarize also according to the template that you choose, so that you may choose sort of the SOAP or the SBAR template. Again, these templates are well used in healthcare. But actually what I found really helpful is some of these actually summarize in the format of your native electronic patient record. So in EMIS, familiar things like the problem, history, examination, comments, and the AI actually transcribes directly into that particular format. And more recently, what we're finding is ambient voice technologies, even coding information. So actually coding information using terminology such as SNOMED directly into the EPR, which then has a huge advantage, especially with general practice, where actually coding is heavily relied upon for all sorts of downstream things such as searches and recalls. So what it really does, I guess, from a clinical perspective, is that it really allows me as a clinician to focus on patients whilst the AI hopefully works silently in the background, as we've heard, taking care of the admin, or at least starting a first draft for you, which we can then amend and edit afterwards. But actually it takes a whole significant sort of cognitive burden away from GPs that are trying to actually multitask. Many of the tools on the market are already being used across the NHS, and I guess the thing to sort of add in here is that many of these are MHRA registered Class 1 medical devices now, and they meet NHS England's DTAC criteria as well. So moving on, I guess, why does this matter? So if you think of a GP, I think it's hard to disentangle this sort of typical image of a GP who'll be tapping away at their computer during a consultation. Gone are the days that we could document where sort of documentation consisted of a few words scribbled, often illegibly, on a Lloyd George record. Notes are increasingly more and more comprehensive, and what we are encouraged to do is write in a way that another clinician could pick up where we've left off. That is obviously advantageous given that we work in larger MDTs. However, it does increase administrative burden exponentially, whereas traditional sort of GPs and the traditional model was, one GP treating one patient, and actually things can be documented in a much more concise manner in that sort of setup. GPs, we know, spend an average of 2 to 3 hours of 2 to 3 hours a day on clinical administrative tasks. So just finishing off writing letters, writing up their notes, coding things that weren't coded at the time in real time. And all of this really contributes to burnout, which ultimately can affect patient care. So I think, GPs frequently multitasking, I mean, certainly sort of, what we battle with on a daily basis is we may have a cathartic consultation where it's sort of, high emotion. And then what we need to do is multitask that with trying to document something rationally in a concise and clear manner. And I think reducing that cognitive burden can make much more effective person-centered consultations, really allowing clinicians time to care without worrying about leaving a few minutes to complete the notes once the patient has left their consulting room. Ambient scribes, I think, offer genuine opportunity to reduce this administrative burden. We know that some of the early evaluations show that 4 or 5 minutes are saved per consultation, which can actually reclaim sort of an hour or more per day of admin time. And we also know from the studies that actually those that use these feel much more focused, less fatigued, and much more present, really allowing for effective, empowering consultations to take place. But we do need to, I guess, be mindful about how they're implemented and be mindful of the current regulatory framework around these ambient voice technologies. So basic transcription doesn't influence clinical decision making, and therefore isn't a medical device. However, any AVT which summarizes, and most of the new ones do, they're essentially considered a medical device, as summarizing essentially influences clinical interpretation. If the AVT goes further and provides calculations, so I mean, I think a great use case for me, certainly, I spent some time today with a manual calculator, literally this morning in clinic, where a patient actually brought in their 7-day blood pressure readings. So working out their average 7-day blood pressure readings, took some time to do on my phone using the calculator app. Actually, just having the ability to read those things out for the AVT to pick that up and give me the average blood pressure, that would be brilliant. But that in itself, that capability would then elevate that from a class 1 to a class 2A device, because it's actually now giving you a calculation. And then sort of for it to be a class 2B, it would have to give you direct clinical recommendations, which actually you can see things are not far off, okay, age less than 55, and actually consider ACE inhibitor, blood pressures elevated, etc. Those sorts of things you can see that happening, but that would elevate it to B status. NHS England's guidelines is really clear on these tools. Any tools that output structured clinical documentation must be UKCA or CE marked. They must meet DCB 0129 standard for the manufacturer, DCB 0160 standard for the deploying organisation. You need to have a clinical safety officer, hazards log, safety case, etc. that go with that. It's really important to note that some ambient tools were actually paused for not meeting these requirements as well. So it is important that as we become really enthusiastic and start to adopt these en masse, we pay attention to ensuring that these tools meet the regulatory requirements. We also need to consider accountability, and I'm not going to go into this, it probably is for the panel discussion, but things like, what if the AI mishears something? What happens when background noise interferes with transcription accuracy? What about AI hallucinations? And people hallucinate, they see things that aren't there. Turns out AI can see patterns or present things as facts that just aren't so, depending on how the models were trained. So to close, ABT, I guess, for me, has huge transformative potential. It can hugely improve how I conduct my consultations, and I think used safely, ambient scribes could really give us something that we've been missing, certainly in general practice, for a long time, and that's space to be fully present with our patients, while the admin, the holy grail would be, by and large, the admin takes care of itself. Thanks for listening. Back to you, Ali.
Thanks, Nilesh. It's so fascinating. A couple of points I'll touch on at the end once we get to our panel questions, but the regulation element that you touched on, I think, is particularly interesting, and also because I guess we've talked a lot already so far about the potential positives and the productivity side, but the what ifs you briefly mentioned at the end there, I'd love to go over those a little more as well. So thank you very much. But what I'm going to do next is hand over to Ross, who is our next speaker for the day. Thanks, Ross.
Thanks, Alison. Thanks for the invite. I'm a consultant surgeon at St George's, and so I can kind of give the secondary care side of Nilesh's talk in a way, because he's covered a lot of the stuff I would go over. I've essentially got so frustrated with our system that I've actually developed an ambient voice technology platform myself with 2 other colleagues. And what we've tried to do is essentially make something that the NHS can afford and that actually takes burden away from the clinician. If we look at what's happened with a lot of ambient voice providers, is that they can very, very easily create a conversation into a letter. There are now 130 providers in the UK doing ambient voice technology. That in itself saves a bit of time, quite a bit depending on what your dictation software is. But if your dictation software has got a very good voice to text, it doesn't save that much. The key here is integration and doing coding and orders. Because if I look at I've got a couple of things to show. Shall I just show a slide? But if we look at these 130 providers, as Nilesh says, it's pretty critical what the kind of loops you have to jump through to get these compliant now. And of the 130 that are available, only 9 are fully compliant with the NHS toolkit, if you like, or the NHS guidance that's recently been released. The other thing to add to that is there's a reasonably large section of that saying it must be integrated. So we don't want to go back to having 5 or 6 web pages opened at the same time where you have to click from one to the other. And so that has been highlighted in the thing. So we've essentially teamed up with another company to essentially integrate into electronic health records. So if we look at what we do after seeing a patient, we essentially see the patient, dictate. That dictation goes off, in our case, to India. It gets typed up, comes back between 2 days and 2 weeks later with multiple errors that we have to then log in, go in and recorrect. We have to do all the coding ourselves. We have to do the RTT, OPCS, SNOMED, ICD-10, and then all the orders. So if we just do the standalone dictation using ambient voice, we can save 2 to 5 minutes, depending on how long your dictation is. But all the other things that we're doing, if we're ordering tests, if we're doing the coding, if we're ordering the follow-up, we now have to book our own follow-up appointments. That takes around, on average for me, 10 minutes per appointment. So we've now been trialing this. We're the first company to actually get a long-term contract with a trust, and we're going live in a couple of trusts imminently. And what we've seen when we've been trialing this with kind of pilots is that in early adopters who are keen on this technology, you can add another 3 patients to a half-day clinic. So for me, I can comfortably add 3 patients to my morning clinic. We're going to push this out kind of more widely, saying that you can probably do 1 more comfortably on average for everyone. But I think the amount of time you can save per appointment is huge. I'll just go on to this next page. So this is just a bit more about how it works, but we've obviously focused a lot on the outpatient clinic, and the use case here is kind of perfect because it takes a lot of the burden away from the clinician. but also does stuff that we don't do. So for example, the OPCS coding, which is coding for, say, if I put a plaster on someone or if I change a dressing, we're supposed to code that and write it down. The trust gets paid for it. At the minute, no one knows those codes because they're very complicated. They're long and they don't make any sense. So essentially people don't write them down, but this essentially does it for you. The next thing that's important is when you've had this consultation, if I say, for example, I'm going to send you off for some investigations, it will then automatically code the RTT status and put that straight into the electronic health record. Now, if we were to do that throughout the whole of the NHS immediately, we could potentially take a third of the waiting list off, because at the minute, the RTT delay from the fact that there's no one in the back office to input them into the system is between 6 weeks and 6 months. So there's millions of patients that are waiting, that have had their clinic appointment, that said they're discharged, or they've had their operation that's been done, that's not had a formal RTT status complete. So we are just touching the surface here, because this is perfect for ward rounds, for MDTs. We've trialed it in ED. I've even been doing it in surgery, so that I speak my operation note towards the end of the operation, and the operation note is already ready to go at the end. This is very briefly what happens. You get essentially the audio recording of whatever encounter it is. It goes into our application, goes through an integration engine, and then goes directly into, in our case, Cerner, which is the one that we're integrated with. But at the same time, this also goes directly into the patient app through the patient portal, so that after you've done your consultation with the patient, within a matter of seconds, they can have this letter on their app, where they can read it, they can check it, they can then share it with their friends and family. They don't have to wait 2 weeks plus for the paper letter to come, which may or may not have errors in it. It's also changing the way that the patient and the doctor interact a bit, because essentially the patient is then being a part of creation of this document, and in theory we hope empowers them and maybe engages them more in their care. So I think I've done just about 5 minutes, so I'll stop there and open up.
Thank you so much. Oh, sorry, I thought my dog was going to start barking there. She's behaving. That was really interesting. And it feels like we've got, I know Michael's still to talk yet, but you get to the end of that and think, why wouldn't we? Why aren't we? But I guess the question will come to is what are the cost and the implications to roll out this kind of tech. So, but before we get to questions, because I keep interrupting, Michael, we'll hand over to you if that's okay, and you can talk as well.
Thanks, Ali. So I am a director in Capgemini, so have a slightly different view on this, having spent a big chunk of my career delivering technology into the NHS and seeing firsthand how difficult it can be to have new innovation adopted in a healthcare setting. And I think there's quite a fundamental difference between rolling out a piece of technology and actually really fitting it in and around what healthcare professionals and patients really want and need. And when we're talking about things like ambient AI, I think that starts with our ability to train our clinicians and our healthcare professionals to be able to have a conversation about what AI means to a patient, to a clinician. Because with all of the AI's captured the zeitgeist at the moment, and there are lots and lots of armchair experts. So you have varying degrees of knowledge about what AI is, and sometimes very polarizing opinions and skepticism about what AI means to a patient as an individual. And so we can talk about how much time this is going to save and why this is great for clinicians, but unless we arm our clinicians with the ability to be able to talk to patients about, yes, I'm going to be using some ambient AI when I'm dealing with you and treating with you, whether it's a scribe or it's monitoring systems or wearables, things like that. We need to be able to talk to them in a way that says, actually, this is how we're using the AI. This is why it's safe. This is why it's ethical. These are the risks involved. This is how we're mitigating those risks, and make them as a patient feel really comfortable about the use of this technology in their care. So I think that's number one. And the other, that's from a patient perspective, but from a clinician perspective, AI is going to solve a lot of challenges. Ross and Nilesh spoke eloquently about how much time it could save them, how it's going to improve patient experience. But that could very easily have a downstream impact on the rest of the health system. If there are more people coming through the front door, you're able to deliver more appointments. What happens to downstream processes, downstream operations, surgeries, MDTs? How do they cope with that additional demand coming their way as the front door essentially gets wider? And so it's about actually how do we track that through and make sure that the benefits are realized? Because it's great when you have a really engaging consultation with a clinician, but if you then have to wait 9 months for a follow-up because actually the people downstream have just had loads of people thrown over the fence at them and have no ability to mop up that kind of demand, then it's going to impact patient experience. And then from a business perspective, if we have all of this change happening, and Ambient Scribe is a really good example, is there's huge demand. I've spoken to lots of clinicians who are crying out for this because it saves so much time, because it allows them to have more meaningful conversation. Then this kind of technology is going to spread like wildfire. And the challenge with that in the NHS, as we all know, is that it's a cash-constrained organisation. And so if I'm going to have to implement this technology and I'm paying, as with lots of subscription services and cloud and AI services, on a usage basis, and it spreads really fast, but I'm not fast enough in decommissioning the systems and my contracts with my dictation providers fast enough, then it's not going to be cash releasing. It might be time releasing, but it's not going to be cash releasing. So how do I make sure that I can continue to afford this service, as even though it's going to release productivity, if I don't have the cash to pay for it, I'm going to end up in a hole. And so I think that there's huge benefit for it. There are risks as well, as Nilesh touched on. We need to be able to peer inside these LLMs. It's technology that's constantly changing, it's learning, it's evolving. So how can we look into that technology and understand what decisions is it making, and are those the decisions we want it to make, and making sure that we understand what the never happen scenarios are, how we put guardrails around those to make sure they don't occur, and then where are the tolerable errors that we are willing to put up with, and how do we identify those in a systematic way and correct them and enforce those corrections. So from my perspective, when we're looking at implementing new technology in a healthcare setting, the number one question is, do the risks outweigh the benefit? In this case, categorically no. Right, there's so much benefit to be had for this. We have clinicians who are having deeper interactions with more patients at any one time. We know that patients have higher satisfaction because they feel listened to and they feel heard. And as Nilesh said as well, the burnout rate has been shown to drop amongst clinicians who are using scribes pre versus post. So I think this is an incredibly exciting space, really great technology. As with everything, not just in the NHS, but broadly, it's not just about the technology. That's only half of the answer. The other half is actually proper implementation, change management, and making sure that we're winning hearts and minds along the way, which is kind of difficult to do when half the people using this technology are not NHS employees. They're the patients, they're the general public. And how do you do that education, and how do you get them on board as well?
Thank you so much, Michael. That was also another really interesting perspective. And I like that you touched on cost, because, I think that's going to be a really significant question. And you made the point there at the end about the risks not outweighing the benefits. Great. But your question earlier about how can we afford to have these services, is an important one and not to be ignored. So thank you very much. So it's really helpful to get four very different perspectives. Ross, do you want to come in on that quickly before I start with other questions?
Yeah, just quickly, because I think it's quite funny. The cost of these ambient voice providers in the States for the Epic one is $50,000 per clinician per year. So just put that out there. There are some providers in the UK, and one of the other US providers is touting $600 per month. And then one UK provider is suggesting £600 to £700 per clinician per user per year. So if we were to put that in at St George's, that would be £4 to £5 million per year, which is more than we pay for our EPR. So the costs are way out. This has to come in at the same price as dictation, otherwise it's impossible.
Yeah, it's a really good point, and no doubt you'll end up getting some questions about that at the end as well. I've got a couple of questions here. We'll try and get through them, but I want to have time for the audience to ask questions as well, so I may pause them if it's looking like we run out. I was going to ask you all super quickly a question for everybody. Everyone's touched on slightly different points about ambient AI. I guess actually the answer to this is probably yes, because my initial question is, do we think that it will benefit the health and care sector, but should it be introduced as a single use case initially? Perhaps it's that ship has already sailed if people are using it, but I'll pop that to you first, Wahbi, just go in order.
I mean, yes, 100%. I do think it's already benefiting, I think. I think what will be interesting is to see whether because we've talked a lot about ambient voice technology, whether the other ambient technologies, such as camera-based technologies or sort of infrared, will benefit individuals at home, these sorts, or on wards themselves, right? So you're looking at deterioration on wards. Should it be introduced for a single use case? Again, yes, I see it. You have to introduce things. You tackle problem by problem. I mean, that's the only way you really can develop a company that actually will be funded at the end of the day. And that's what you need. You need a company that will be funded, and there needs to be a clear route to a business and profitability at the end of it.
Thank you. Thanks. Great answer. Nilesh, do you want to expand on that at all?
I mean, I think sort of well, we said it really. I think the potential for ambient AI in healthcare is huge. I think I'm less familiar with some of what was described in terms of the cameras, infrared, etc. I think that again, I can see immediate sort of benefits, especially sort of when you look at some of the models regarding hospital at home, keeping people well at home. Again, I can see a huge potential there. But certainly for ambient voice technology, something that I've used myself, I think the benefits far outweigh the risks. We do need to implement them safely, but I think if we look at the challenges that are currently facing the NHS in terms of sort of numbers of consultations actually happening versus demand, but also the amount of time spent on doing things that could actually be automated, could be supported by technology, we always have to adopt it. I think if we're going to have sustainable healthcare going forwards.
Thank you. Michael and/or Ross, have either of you got anything you want to add on that one?
I would just say very briefly, 100% agree with the others, but I would caveat it with it needs to be nationally driven. It needs to have a set number of suppliers, and I am not clever enough to work out how many that should be, but it certainly should not be 1, and it certainly should not be 20. And the reason for that is you need to be able to control a bit about the kind of market. You need to make sure there's enough that it makes it competitive, that people still keep improving their product, but you don't want to have so many that you lose control. There've already been some court cases in the US where providers of ambient voice technology there have been sued by patients because they said that's not actually what happened in the consultation. And the ambient voice provider has said, well, we don't keep a recording of it, so we can't say one way or another. So there's a lot to go through here, and like keeping control is important.
The only thing that I would add is I agree that this is an emerging market, and so startups and SMEs in this space should be focusing on a single use case. The NHS should not. There are lots of applications for this technology, and there's lots of potential, and there should be space for the NHS to be able to safely and ethically experiment with this technology to see what kind of gains we can make in terms of patient outcomes, experience, and clinician experience too.
Yeah. Thank you. Those are all great answers. I've got some other questions, but I just want to go to the chat because there's 3 questions in there and they're similar themes. So one person is asking about compliance with safety regulatory standards. If they aren't, why is the NHS even considering these? Another person is asking about validation of AI scribes as a medical device to make sure that they're accurate. And another person as well asking about accuracy of responses, what mechanisms are in place. So those generally all feel like they're about regulation and accuracy. So I wonder if anyone wants to pick up any answers to those before we carry on other questions.
I'm happy to talk a bit about accuracy, if you like, because when I use this now, I say I would maybe edit 1 in 10 letters, and most often that edit is because it doesn't spell my name very well. And the rest of it actually often says it better than I would have said it. If I go back through the letters that I've typed myself, because I've actually given up dictating because it's too annoying, so I actually type them, and I look at the errors that I create by typing them myself in real time, they are not error-free. The error rate is probably 5 to 10%. And then if I go to my dictated letters, it's much higher because sometimes they're done at a time period after I've actually seen the patient. So I actually think this technology will make the error rate drop.
It's a really interesting viewpoint. Does any of the other panel want to come back on that?
I just come in on the validation part of things, in terms of validating, and it's a really good point. How can we basically explain why the AI is making the prediction or the kind of producing what it's producing? A lot of research is being done at the moment in trying to develop explainable AI systems. So can we explain, why this error was done? And I think that's quite important to quantify this uncertainty in terms of a regulatory framework. So I think we are getting there, but we're not quite there with validation. But I think it's super important to have.
Thank you. That's great. Nilesh, go for it.
Yeah, just to add, when you look at a lot of the ambient voice technology models and their use of large language models, one of the things that I think we need to sort of really have at the forefront when we're using these technologies is that large language models like GPT, for example, they essentially their primary function is to generate human-like language. And the primary function isn't to ensure it's the most accurate information out there. And that goes for sort of people using ChatGPT type models for individual research, but also when applied to this kind of ambient voice technology in healthcare as well. It's going to present information which sounds human-like, but we need to ensure that the accuracy is there. Ultimately, when we click save onto the patient record, we are responsible for what's actually saved in that person's record, irrespective of which tools you use.
Okay.
You don't blame your stethoscope for hearing something and then noting it down. In the same way, you can't. It's difficult to sort of say, well, actually, the AI got it wrong. Yes, the AI may have got it wrong, but you had an opportunity to correct it before you saved it. So we need to bear that in mind.
Yes, there's this personal responsibility in there, which is a really valid point. I'm seeing some more comments come in on the chat. There are more comments than questions, so I'll come back to those in a second. Wahbi, I wanted to ask, in my previous role, I was working on data and AI cross-sector. Obviously, we're talking about health and care here today. It feels to me like health and care is moving very fast in the world of AI, but would you say we're slow to adopt, or is it quicker than other sectors?
Briefly, I would say we're slow to adopt, if I'm totally honest. I'm an engineer by background, sort of a mechanical engineer was where I started off. And, if you go to civil engineering, if you go to mechanical engineering, the use of AI has exploded in a way where it's actually being implemented and creating real returns for individuals and changing the way practice is done. A really good example of this is sort of building site AI. It's kind of ambient AI, but for building sites where you've got the cameras around, they're looking what's going on and they're doing the just-in-time orders. So you don't have girders lying around and bricks lying around, people not doing what they need to be doing, right? So it's saving a lot of money for construction. That's being used and rolled out as we speak and saving lots of money and lots of time. So I think we are way behind, but I think there's a reason we're way behind, and that's because we're not dealing with inanimate objects, we're dealing with human beings, and that kind of leads to a whole different ballgame of regulation, ethics, and it's correct that should be in place, and it's correct we move slower because getting it wrong has a lot more consequence than sort of not delivering a pallet of bricks on time and losing a bit of money. So it is developing rapidly and it is exploding, I think, in the health sector, particularly in research, but the translation from research into clinical practice is what's missing at the moment, I think, because the stuff I read about and do research on, it's mind-blowing, the stuff that's going on, but it's not being translated. And I think that gap still hasn't been crossed yet.
Thank you. It's a great answer. Nilesh, I wanted to ask you, because you've talked about sort of lived experience of using these tools, how your patients react. I think it was yourself or Ross, somebody touched on communicating and about making sure that you communicate well with your patients about the fact that you're going to be using these tools. I'd love to know how that communication has gone.
Sure. So I think for those that I've actually used it in, because we're not using it sort of widespread across the board yet, we've still got a few governance issues to get over for that. But for the ones that we have used it on, they absolutely love it. So, I think being able to talk to them directly, not having the distraction of a computer as the third consultant in the consultation room is really helpful. Being able to look them in the eye when you're actually having potentially a difficult conversation, difficult consultation, bringing in that sort of the humanity of the consultation back into it, I think speaks volumes. And certainly, patients, once they get over the initial, well, what is this doing? And you've explained what it's actually doing, they are, fine with that, and actually feel like they can get more out of the consultation, they can get much more value out of the consultation as well, and they can talk about things in more detail than they perhaps otherwise would. Certainly some of the more polite patients do consider that actually that there's a part of the consultation which requires documenting and doing a lot of the admin. This actually allows a bit more time. So yeah, from my experience, they love it. Colleagues also love it. I haven't spoken to anybody that actually feels that, tried it and absolutely didn't like it. I've got, indirectly, I know of those that were approaching sort of retirement and essentially sort of delayed it for a little bit because they've tried this and thought, actually, this is really good. So there are some really, really good success stories there. And the research that's coming out in terms of using ambient voice technologies as a tool to combat burnout, it really is. There's a lot to it there. I think, the benefits are huge.
Thank you. Ross, we may have covered this question, but I'll ask in case there's anything you want to add. Clinical risks associated with ambient AI, and how would you manage that yourself as a clinician?
So when we first started developing this product, we just had the very basic product, and what we found was even if you didn't say some things in a consultation, the AI would fill in some gaps for you or make something up. So, for example, if I saw someone with an ankle sprain and I said, I think you've got an ankle sprain, but I'll send you for an X-ray and I'll see you next week with the results. AI had then put in at the bottom, we would also recommend that you elevate the leg, put ice on it and rest it during this period. I was like, actually, that's quite good. I wouldn't mind that in my letter. But we did actually then think, well, there is a risk because it could say something that's completely inappropriate, like you should go and carry on exercising, run as much as you want on this because it's good to keep active, for example. And so we've then developed something called AI Strict and AI Assist. And AI Strict is where it just does exactly what you said. And AI Assist, it will give you tips. And this is where Nilesh was talking earlier about where we're starting to creep into to class 2 medical devices. And you can very easily see how this does develop into, well, it sounds like this patient has a ligament injury, and therefore we would recommend the patient has an MRI. Would you like us to book this for you? Oh, yeah, there it's booked. And very soon the clinical decision making comes out of it. So you can see how this technology will move on. And I mean, even in a year since we've been doing this, the speed of how much the technology is advanced. Originally, it was taking us 30 seconds to a minute to create a letter. It's now taking 2 or 3 seconds. It's insane how fast it's moving. So I can see this happening more, and there's definitely more of a risk. And that's why if you start to go down that route, regulation will need to be higher. At the minute, this is all on the doctor and or in theory, the trust. Mm-hmm. So the risk is with them, but there is definitely a risk. And I think that will be greater as it does more.
Yeah, and I guess then the regulation has to catch up as well as the next element to that. Michael, I've got a question for you, but there's one in the chat first that I'm not sure if anyone is interested in taking, about how this type of technology works for language translation for patients that don't speak English. Has anyone had experience of that or wants to talk about it?
I'm happy to take that if no one else is, because we've actually we had what I thought was really cool, because you could basically immediately translate. So you could translate as it was speaking, and also you could then translate it into whatever language the patient wanted. So what we were demoing at the start of this, that we were translating, we had a letter in English and a letter in, say, Spanish, put into the patient's app. So while they're in the room with you, they've got the letter in their language. But then annoyingly, the NHS guidance said the responsibility for the quality and the content of the translated letter falls with the ambient voice provider. And we can't do that yet, because in theory, we need to actually probably put this through tens of thousands of examples of, is this definitely correct? We've shown it to people in the, and they've checked it and they say, yeah, it's good, but actually we need to do it robustly. But 100% that's the future, because in theory, you could have a consultation like that without language line, which is pretty expensive, and you can have it immediately translated on the screen and then put in English and in the right language in their notes. So yes, but it's future.
Thank you. And that's someone asking a question along the same lines there, but about a person who's non-verbal. How would that be managed? Can it be, I guess, is the question.
No
No.
experience. I can't imagine that working.
I can't imagine how it would work either. Thank you. Michael, my question for you was about the idea of a digital hospital and the shift from analog to digital, and where you see ambient AI fitting into that.
So when anyone talks about digital anything, it's usually followed with the foundation for that is high quality data, and that needs to be in place. I think I'd go one step further and say the bedrock of that is actually a consistent and effortless way to capture that high quality data, because there's no point in having high quality data at a point in time and then that getting eroded because people, it's too much work, it puts too much of an imposition on the teams and on the clinicians in order to maintain it, and so the quality drops off. So from a digital healthcare perspective, I see ambient AI as that ability to capture that high quality data, and so you can continue to build upon that. You don't have crumbling foundations, and you can then have digital healthcare, and then taking that into reality, into actual practice. I think especially with ambient scribes, they have the potential to be the interface between healthcare professionals of all types and the system. So it's not just about integrating with the right system and publishing to the EPR, but if you're able to level set information across a care team in a way that anyone can understand in their lens and their way of viewing that patient, then I think it will help massively with collaboration across the NHS.
Yeah, good points. Conscious of time, and people have been very kindly putting their comments and questions in the chat already, so we've covered a few things, which is great. But is there anyone who would like to stick up their hand and ask a question to the panel in the last couple of minutes? Feel free to do so. If not, I've got another couple of questions myself. There's more comments coming in. I'll just read this one out then. What are the IT and infrastructure issues for implementing AI? Can this be done with the current infrastructure hardware? And that was actually one of the questions that I was going to ask about potentially outdated tech in GP offices and that sort of thing. Would anyone like to touch on that?
I think so. Most AI services are running in the cloud, because you don't want to have, or it's very difficult to have an AI model running on premises where you're sort of limited by the amount of compute that you have, and it's a huge investment up front. So from a hardware and infrastructure perspective, in reality, all you need is an internet connection to be able to start using the technology. Clearly, there's lots of data, ethical and governance restrictions and security restrictions that need to be satisfied before you can do that. But switching this technology on is pretty easy.
Anyone else want to comment on that? Steve, jump in. Feel free. It was your point on the chat there. Go for it.
Yeah. So I suppose I was wondering from the point of view of a GP practice where you've got a limited bandwidth, or it appears to be limited bandwidth to outside structures for running your IT system as it is. So something like this, is this going to mean that you need to increase that bandwidth? You're saying it, the tech is all offline, so you don't need hardware within a practice, but do you need, is your standard NHS connection going to work? I'm going to allow this to work. That's really what I'm thinking.
Yeah, if you don't have any internet connection, it obviously doesn't work. But if you have borderline Wi-Fi, it works. You can use it on 4G, 5G, for example, it works. The higher, the better. But we, on standard NHS Wi-Fi, we've managed to make it work in hospitals. And I would say the Wi-Fi in St George's in particular, you can't do a WhatsApp call on it because it's so poor, but this manages to make it work. So if that gives you a kind of level. The problem with hospitals, and I'm sure some GP practices as well, is that you get black spots. So there are places where you don't actually get very good signal. So we're kind of working on things where you can have memory that kind of stores the conversation and then does it when you come back, but it's a bit of an IG headache, that. So in answer to your question, you don't need much.
Thank you. Thanks, Ross. Do you want to jump in? Is it on the same point, Ian?
Yes, exactly. It's about the quality of network services. We've had instances in Scotland where the downloading of a single patient's digitized record has taken out an entire region's access to the electronic patient record.
Wow.
So the problem is not the Wi-Fi bit, it's the connection from the physical building into the rest of the NHS. So hospitals will have a big fat pipe and you won't have to worry about that. GP practices will often have a much smaller pipe, and without correct network management, that can literally cripple the system, particularly when your GP system is now hosted offsite. In many cases, you also have your telephony running over the same channel. And so you basically run out of space. And the NHS does not have the kind of track record that the commercial broadband providers at home might have around traffic management. And so I think the running in the cloud being the magic solution isn't necessarily the case, because you need to absolutely ensure that you've got the right quality of service metrics for that kind of traffic flowing to that endpoint. We've learnt the hard way and have now introduced specific quality of service metrics about specific kinds of traffic running through our networks in Scotland to prevent that sort of what you might call lane hogging by one kind of traffic. So it's one of these things that needs to be considered as part of the overall implementation. Thank you.
Thanks very much, Ian. And actually, that's a nice point to end on, because I was going to talk about, I talked in the beginning about potential themes for future events, and Michael and I had talked about possibly having another event about implementation of AI specifically. But given the things that have been discussed today, I wonder whether there's also space somewhere for a regulation and compliance conversation as well. So I'll jot all these ideas down. But unfortunately, we are out of time. And I feel like there's probably much more that we could have covered, but we've come to the end of our time. And thank you ever so much to all of our speakers. We really do appreciate you coming along and sharing your expertise and your insights.